Hi, I'm Meta Spencer, and today we have a very important conversation because, of course, there's an Ebola epidemic, or maybe a pandemic, I'm sorry to say, in Africa now. And we have some experts here who are going to talk about that. I'm going to introduce my friend Neil Arya, who's a physician in Waterloo, Ontario, and the director of something called Pegasus, which just had a wonderful conference here. And just ask him to introduce his colleagues and friends here. So good morning, Neil. Take over.
Good morning, Meta. Yeah, it's a real pleasure to be here, and it was great to have our conference a couple of weeks ago. We were doing some Pegasus presentations prior, and we hope to do this twice a month for Project Save the World. Pegasus is a Canadian educational charity focusing on global health at its nexus with peace and sustainability. And so we're really fortunate today for having some experts basically within our network who've dealt with Ebola before in different contexts and dealt with things from the very macro to micro. And so it's a great pleasure to introduce Ron St. John, Pakista Tshimika, Nancy Graham, and Yogesh Chaudhri. So I will begin with introductions with everybody, perhaps starting off with Ron, then Pakista, then Nancy, then Yogi. And as you introduce yourself, let us know a bit about your experience with Ebola and perhaps other infectious diseases, pandemic type things.
I'm Ron St. John. I'm a physician epidemiologist. I spent my entire career in control of infectious diseases and in managing outbreaks of disease. For example, I managed the federal response in Canada to the SARS outbreak in 2003. I retired as the Director General for the Center for Emergency Preparedness and Response at the federal level here in Canada. Thank you.
Pakista Tshimika, and I am now back in Kinshasa, where I am the Executive Director of Mama House of Hope, which is an organization I founded in honor of my mother. After working for several international organizations in public health, as well as in managing or participating in the reorganization of primary health care in the Congo in the 80s. Well, most of my experience, direct experience, have been with the Ebola in 1995 in Kikwit and out there.
Hi, everybody. Nancy Graham. I'm a registered nurse with a specialty in infection prevention and control. In 2020, and I've done 10 or 11 assignments with Médecins Sans Frontières, Doctors Without Borders, internationally in Africa, Middle East, and Southeast Asia. In 2014, I worked for 5 weeks with the Ebola response in Sierra Leone. And in 2015, again in Sierra Leone, as the infection prevention control specialist for a regional hospital, Tonkolili Hospital. But the context today in the Democratic Republic of Congo, Uganda, and South Sudan is very, very different. Thank you.
Hello, everyone. My name is Yogesh Chaudhri. I'm a physician epidemiologist. Just feel free to call me Yogi. That's all my friends and family call me. I've worked in all through my career. I've worked in infectious disease epidemiology, outbreak management, whether it was pandemic H1N1, and then of course COVID, Zika, chikungunya, all across the world. I was in Sierra Leone during 2014-15 outbreak, and I was posted in Port Loko. So I have some experience with Ebola also, and that would be nice to contribute here. Thank you.
Pakista, maybe you could share something, a map, so people are able to get a sense of where things are right now and where you've been?
Let me first make a comment why I'm focusing on the Kilquit experience. For one thing, I lived in Kilquit from 1992 to 94. And I was in Kilquit in 95 because I had invited a North American doctor to work with us in some of the clinics as well as the major hospital in Kilquit. And I still have chills when I think about it because the patient who was supposed to be operated on by my friend, plus a couple of doctors that I knew, several doctors I knew there, was supposed to operate on him and leave the next day for the US. And for some reason, they had gone to another hospital and someone came and told them that the surgery has been postponed for the next day. And so they end up not going back to that general hospital. By that time, I had already left to go to Kinshasa. And then a week later, I'd left to come to, I went to the US for 6 months. So when they went back to the hospital to check what happened, and they were told that they had sent someone to tell them that they were ready for the surgery, they were waiting for them. And then my friend, plus the other two doctors who were there, told them that someone came and told us that the surgery had been canceled. And so why are you saying that you're waiting for us? The result of that was the whole team that had operated on that patient, they all died. The doctor, the nurses, the anesthetists, they all died.
I think you're also implying that at that time, things could have gone to the US quite easily with things being recognized later. And so that's very relevant to what we have now. Yes. Did you want to show a couple of slides?
There have been 17 episodes of Ebola in the Congo. The first one in 1976 with 318 confirmed cases and 280 dying. But then the biggest one also in Kikwit with case fatality of 81 and the first one 88. But since then, they have been dropping in terms of the case fatality. Okay, and here I found a map of the outbreaks from 76 to 2017. Many times it gives the impression that Ebola is everywhere and that is spread so fast throughout the whole country. As you can see, for each year where there was outbreak of Ebola, they are confined to different spots. Oh, by the way, the first strain of Ebola was called Zaire, and but this one is its origin in Uganda, and it's especially in the eastern part of Congo and also in Uganda. And the biggest city where it has shown up so far is Kampala. So people eat monkey, and then even when they find an animal that's been killed or died in the forest, they pick it up and then eat it, was also the reality of the disease. Even now, I've talked to several people here in Kinshasa, and they'll tell me, "Oh no, that's not even. We don't have Ebola. Just like we did not have COVID. It was just a way of trying to get the money from international communities." And then, like now, what's important is also the regional conflict and wars. So you have the destroyed infrastructure, the health personnel killed, restricted access, and then you have a lot of internally displaced who are in confined to one place, and then making the spread of the disease much easier. A lot of health centers, hospitals destroyed, this time at least, because of the war and conflict.
Thank you so much, because it gives us the historical context and how this is really changed. I'd like to refer to the WHO and other organizations' theme of the One Health ecosystem, and that is we human beings are part of an environment with animals and flora, fauna. So, and we affect each other. And in the DRC, as in many other parts of the world, practically every part of the world, the natural spaces are shrinking. So animals are forced into ever smaller spaces. And then there's contact with human beings. So in the DRC, in the eastern DRC, the region, fruit bats are known as the vector of Ebola, the natural vector. So as their natural spaces are shrinking and humans who are hunting or gathering fruit come into contact with the fruit bats. And so that is how the disease spreads. And it's being well understood that we need to learn how to live in those habitats and to respect those habitats and even make sure that they're actually growing. So I just want to point that out about the One World, One Health theme that is being understood today. Thank you.
The restrictions are, in a way, seen here sometimes as being racist in some ways by some people, because there are some North American Europeans who are here who would go to a country that's not on the list of the US for the 21 days isolation, okay? And then from there, they can fly to Canada or fly to the US because they're coming from a different place other than Uganda, Congo, and so forth. So it's being taken with a mixed feelings, at least in Congo. And the other aspect is that there's a unique aspect of this virus because it's not Zaire like all the other ones so far. This one has its origin in Uganda and it's more deadly than the ones before. So the restrictions from the whole country is not seen as being fair because there's a lot of measures that have been taken by Congo itself for people living in those areas not being able to go in or out of the area to other part of the country. Like you saw on those maps, they are confined to the borders between Congo, Rwanda, and Uganda. So there's a lot of
Right.
mixed feelings about all those restrictions.
You have to be very careful. I mean, people don't understand. There are over 5,000 international airports. There are millions of people in the air at any given point in time. If you want to go to some place, you can make different connections, as Pakista said, and what it gets lost is what country you came from originally. So it's not that difficult to move. The critical thing, as it was just pointed out, it's not that you come from the Congo. It's what were you doing in the Congo? Where were you in the Congo that creates some kind of risk? So Nancy, coming back from actually working with patients and physicians and the healthcare infrastructure, yes, that was a clearly correct to self-isolate. But other people don't understand that, and so the real question of stopping the disease at the border is mute. It just can't be done if you really, no matter, unless you shut down the entire country, and that's economically not feasible. Thank you.
Well, let's talk about that a little bit more too. So Uganda has 9 cases supposedly, and so is it going to burn itself out? These cases in Kampala, is Uganda almost safe? Any of you to talk about the science of that, Nancy?
Yeah, it's a really good concept to bring out the map that Pakista showed us earlier of these previous outbreaks. Because people in the DRC, particularly in the east, are more isolated. There's a lack of roads and rail, and people are sort of staying in one area. They're not migrating. The disease would burn itself out. But however, now with movement of people, particularly in the Ituri province, where people are migrating over vast distances because of the mining and extractive industries, the possibility to infect others with this highly infectious disease, Ebola, which is not transmitted through the air. We know that it's through direct contact with bodily fluids. It spreads much more readily. And the regional borders are completely porous. The borders into Uganda are porous. So the ability for the spread is massive. And international experts are very, very worried that this disease will not burn itself out like it had in earlier outbreaks 20, 30, 40, 50 years ago, where they were very localized and people they died and it didn't spread. Villages were gone. So I'd love to hear other people's comments on this. Thank you.
Yeah. And as we move into this discussion more, Dr. Tedros has called for a ceasefire between the rebels in eastern Congo, just south of where where the center of this outbreak is. Could you talk about the importance of trying to do that and the possibility of actually having a ceasefire to help reduce the spread? Pakista?
And I think it's helpful because the humanitarian agencies, the government, can send people in the area, hopefully to move, and hopefully with adequate protective equipment that they can use. Because I think it was shown in the past also that as soon as they brought in more protective equipment for the local nurses, doctors, and it really made a big difference. But the fear for the ceasefire in that region, at least from the Congolese side, has been that each time they call for a ceasefire, that gave the possibility for the rebels and the neighboring military to regroup and send in more soldiers in the region during the time of the ceasefire. So it's taken with a lot of reservation because they don't believe that it would have that much impact on controlling the Ebola as much as it's going to give the possibility for the rebels to regroup and to get more weapons.
We need to look a little bit in a broader sense. It's not a medical issue handling Ebola. It's multidimensional. So I think putting restrictions, urging the rebels not to fight is also part of it. It may have its repercussion, as you said, Pakista. But we also try to control the borders by putting police on the roads. If you remember Nancy in Sierra Leone. So it's multi-dimensional model. Each one will contribute a little bit. It will have its effect, but what did we achieve in putting up fences across the borders in different countries? So I'm not too much in favor, but it will add. Let's see that it may have a positive effect on people. So that's why I say, we need to work with the communities.
Nancy?
I think security is key, and it'd be very interesting, Pakista, if one of the methods of intervening with these militia and government forces and boy soldiers with submachine guns, etc., all wanting control over the gold and coltan, the extractive industries. If somehow we distribute PPE to them, wouldn't it be an amazing photograph to show soldiers in full PPE with a submachine gun? that would be an incredible. You also commented earlier about nurses and doctors in the area needing support for them. There's a displacement camp of over 100,000 people in the Ituri province, and there's one nurse who has virtually no equipment. She's got one box of gloves. So those are the folks that need to be supported. And do we need to maybe hire armed guards to be in those facilities? Do we need to have armed guards working with the international NGOs? Because there's a duty of care when international NGOs are sending international staff into a region, that they are protected to the highest level, that they get to go home. So will it be interesting, do you think, Pakista, that there will be armed guards paid for by the DRC government to support international NGO efforts and protect the Ebola centers and isolation centers, as well as the national staff who are working in very small health centers and or hospitals? What's your opinion on that?
I personally would like to see a consortium of doctors and nurses from around the globe, ending in this case in Eastern Congo, to join the local doctors and to deal with the epidemic. The same way I said, can we do the same thing when there's violence? Would they really be able to kill 50, 100 doctors and nurses coming from around the globe? So my dream would be for a consortium of doctors and nurses to go in the region, join hands, and also get a lot of doctors from Congo to go as volunteers from Kinshasa, from other places, and join the team to go and work with those who are in Eastern Congo and in the camps. so that it doesn't spread to other places.
We all know that armed conflict is terribly disruptive, and protecting the healthcare centers is critical. But then there's the population at large, the population that's not in the healthcare center being treated. And we know that people flee from armed conflict, they disperse. And so you have a problem in an armed conflict situation of actually having people spreading disease because they're fleeing from the conflict. It may be useful. I like Nancy's image of insurgents in PPE, but it may be interesting to explain to the insurgents that they might be equally at risk as the population in general, and maybe they better stop shooting and worry about whether or not they're going to get infected. That may help support a ceasefire situation. I don't know of an example where that kind of thing has been tried. Thanks.
We talked about how these centers are being burned down and people escape from the centers, we believe causing more spread. How do you see developing trust in general in certain contexts? And there will be some differences between West Africa and Congo.
I think we need to work with the community leaders, the church leaders. We did sessions with church leaders and the community leaders. Women group, very powerful. Go and work with them. Listen to them. As you used the word tailored response, and I agree with that. Every situation will demand a different strategy. So you have to go in deep into that. Let the health promotion people work with the community leaders, church leaders. Actually, in some countries, I worked with rebel groups to be with them, and then work. I was in South Sudan working with rebel groups, or in Israel, Palestine areas. Worked with them too.
And indeed, I was involved with measles outbreaks in South Sudan. So a key is not only working with official local leaders, such as the chiefs or the local, police officers, or the heads of militia groups, but indeed working with unofficial leaders. That is your local midwives, local shopkeepers. They're often very, very, and religious leaders. They're very informed as to what's going on. And a key thing, as Meta brought out earlier, is dignity and respect with not only your patients, but also with burial rituals. And indeed, being informed by local unofficial leaders around culturally appropriate practices. But having medical anthropologists as part of your team is very, very helpful. They can delve deeply into understanding subtleties in terms of health and illness belief systems. And so we, as international NGO folks going in to help, as you were saying, Pakista, earlier, glove in glove with local partners, is respect and dignity and listening and learning as you go along.
I think what happened in Kikwit, as well as one experience I had in the 90s, was being called by one pastor telling me about how 15 to 20 people were dying in a certain community per day, and that the government did the test, but they did not do anything else. So I flew to the area and we met with all the different leaders from schools, from the churches, from all areas, the military, the police, and we talked to discover that the problem was they had a market where the toilets were close to the area where whenever it rained, everything went into the river where people were getting the water for drinking. But once the whole community was engaged and few treatments, within a couple of weeks, the problem was finished. And I think in Kikwit, we discovered the same thing, that engaging the community, and they were able to organize small groups that were trained on how to talk to people about the disease in a way that they can understand. That made a big difference for me as a Congolese. It's good to know that there are people from around the globe who are also thinking about what's going on in the Congo. Sometimes we feel like we are alone.
What Pakista and Nancy said about building trust is super important, but I'd like to suggest there's an international trust that needs to be built and maintained. Governments will be pressured as this epidemic evolves. Governments will be pressured to quote unquote do something, do anything, and the chances that they will do harmful things is a real possibility. So there's a need to have that same trust and confidence built internationally as well. Thank you.
Thank you, Ron. Yeah, very sobering words. So we're doing this interview on Thursday, May 28th. I expect by the time this is released in a couple of days, we're going to have evolution of things. Perhaps in Uganda, we'll see some things, and we may see things in the rest of Central and East Africa in the coming days. Each of you has suggested other people who might be involved in further discussions. Dr. Muyembe, who is credited with having discovered Ebola in the 70s. Nancy has suggested the head of MSF in Canada and internationally at some point. And we will have further discussions with Pegasus on Ebola. But this does tell us a little bit more about our interconnected world, our need to respond to the natural environment and taking an ecosystem approach. So thank you on behalf of Pegasus and Meta. Did you want to say a final word?
Yes, I just want to thank you, Neil, for the helping organize this, and thank you, your friends and colleagues. We need to keep our ear to the ground, and I'm afraid this epidemic is not anywhere near the end. So it may be going on for quite a while, and this facility is here. So we can do it again as more information comes in, and as we need to help spread the advice that you have given.